أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم أما بعد أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Our dear students, hope you will find. I'll start this lecture with this prayer that मुसीबत और बुराई बीमारियों को हटा दीजिए. Last time we have completed our lectures on various conditions of the small intestine. This time I will present the total one condition which can involve both small and large intestine. That is a case of abdominal distension. So our today's task will be to handle a case of abdominal distension. To discuss this case, we will be having our case to learn its common presentation of intestinal obstruction, various investigation required for intestinal obstruction, common causes of intestinal obstruction, and the differences between small and large intestinal obstruction, and the non-surgical and surgical management of intestinal obstruction. Because when you know better, you will do better. This is our learning objective. Starting with the case history, an emergency, a 54-year-old man presents to the surgical department with a full-day history of abdominal distension with central creaky abdominal pain, vomiting, and constipation. On further inquiry, he says that he has passed a small amount of lettuce yesterday but none today. He has had a previous history of explorating at what we call some acute abdominal conditions. On examination, this patient had 90 heart rate per minute, which was regular, with blood pressure of 100/75 millimeter of mercury, temperature of 98.6 Fahrenheit, and on examining his abdomen, it was obviously distended but very mildly tender, mainly in central position of the abdomen. While hernial orifices were clear, there was no line tenderness, and rectum examination was unremarkable, while his bowel sounds were hyperactive and high-pitched. And on examination of chest, nothing abnormality was detected. In this brief history, what comes in your mind and how will you proceed with other investigations? Yes, you are right. We will start with blood complete examination, and his biochemistry revealed as hemoglobin level of 12.2 gram per deciliter, with white cell count 10.6, platelet 435, sodium 136, potassium 3.7 milligram per liter, urea 6.2 milligram per liter, and creatinine 77 micromole per liter. What will you advise next investigation for this patient? You are right. We will order plain radiology of the abdomen, and the type of this radiology should be as plain X-ray of the abdomen in erect position. This was his X-ray abdomen. Please look at this and try to give me your findings. What are your findings? What is your answer? The answer is multiple F2 levels. With this few investigation, I am questioning you that what is your diagnosis? What features on the X-ray point towards the diagnosis? And how this patient will be managed in the emergency? And what are the common causes of this condition? So, answering first question, what is the diagnosis? Can you tell me what is your diagnosis? abdominal distension due to small bowel obstruction. So what are the cardinal features favoring the diagnosis of intestinal obstructions? The vomiting, pain abdomen, distension, and constipation. You know, the history of this patient reveals all of these features in history. So our diagnosis is small bowel obstruction. So what are the general causes of intestinal obstruction? These are like this. Most common cause is diffuse bowel disease, which is present in 60% of these cases, and neoplasm, which are in 20% of cases, with herniation in 10% of cases, while inflammatory bowel disease comprises 5% of these cases of intestinal obstruction, and in less than 5% of disease, few other causes are present like interception, bolus, and the other conditions. Oh, here are a few pictures in clinical pictures in front of you. Can you tell me what are these? Look at these pictures. What are they showing? These are showing the dilated small bowels with the staphylococcus pattern. So this is present in case of small bowel obstruction. You may come across with such type of intestinal obstruction, and you may pick up this finding in your cases in the emergency. So what features on the X-ray point towards the diagnosis? There are various X-rays of small bowel obstructions. These may be having distending jejunal lobes with the central valvular cavities and having a multiple air fluid levels. So next question is, what type of intestinal obstruction? Is it a small bowel obstruction or large bowel intestinal obstruction? Can you tell me? The differences between small and large bowel intestinal obstructions are that large bowel will be having dilated lobes in the periphery of the X-ray, and when the diameter will exceed 6 centimeter, it will be manifested in the X-ray abdomen, and there will be presence of hostration in case of large bowel obstruction. While in small bowel obstructions, they will be evident when the diameter will exceed 3 centimeter in maximum diameter, while in spite of, in contrast with large bowel obstructions, these dilated lobes will be having a valvular cavities. What are the difference between high and low intestinal obstructions? As you know, small bowel have different segments, duodenum, jejunum, ileum. So patient can be having obstruction at various level on these segments of the small intestine. So if obstructions, depending on the level of obstruction, these are called high or low intestinal obstruction. So in case of high, the beginning is usually with acute sudden onset, while in the low intestinal obstruction, the incidence is slow and insidious. While the general condition in case of high obstruction is more early compromised, while it is preserved in low intestinal obstructions. Pain will be more in case of high intestinal obstruction, and that is cramping in nature, while it is less in the low intestinal obstruction. While vomiting is an early feature in the high intestinal obstruction, it is manifested as early, profuse, and biliary in origin, while it will be late, frequent, and sometimes it is absent in case of low intestinal obstruction. While abdominal distension in case of high intestinal obstruction will be of more moderate in nature and located in the upper quadrant, while it will be early in case of low intestinal obstruction and it will be more intense. While constipation is less frequent feature in the high intestinal obstruction and it is more marked in the low intestinal obstructions. And there will be more rapid loss of electrolytes in case of proximal intestinal obstructions, while it is late in the distal intestinal obstruction. There is another type of classification according to the degree of obstruction, and there are three types of intestinal obstruction. One is partial small bowel obstruction, which is when there is passage of gas and fluid but no solid contents. This is called obstruction. There is second variety, which is complete small bowel obstruction, when loop is obstructed and there is obstructive proximal but distal collapse of the involved segment. For example, volvulus of the involved segment. And third variety is strangulated bowel obstruction. So, what will be the goals in its diagnosis? The goals are that we should be able to distinguish between mechanical obstruction from ideas, and we should be able to diagnose whether it is partial or complete obstruction, and what is the difference between simple and strangulated obstruction, and lastly, but it is not important to know the etiology of this obstruction. Do you need any other investigation in case of intestinal obstructions? Right, you can use ultrasound of the abdomen and ultrasound. Here is a picture of ultrasound in case of small bowel obstructions. There will be distending loops of the bowel, and here you can judge the diameter of the dilated segment, which is more than 2.5 centimeters in diameter, fulfilling the criteria of intestinal obstructions. And on your right side is Lecula circularis, and this sign is called keyboard signs on ultrasonography of the abdomen. We can further proceed in few cases with CT abdomen. Again, this is a topographic picture of small bowel obstructions depicting the dilated loops of the small intestine, which are mostly present in the pelvis of these patients. This is a coronal section and this is a sagittal section of this. In other few cases, in chronic cases which presents as acute intestinal obstructions, you can go with contrast radiology of the small intestine, and these arrows are showing the collapsed segment or level of obstruction in case of small obstruction with proximal dilatation of the loops of the intestine. So, having reached to the diagnosis of small obstructions, next phase comes is how will we manage this case. So, what will be the steps for the management of this case? These are the general in principles. Starting from the patient should be nil by mouth. In small bowel obstruction, there is substantial fluid loss and intravenous fluid resuscitation is required. So, IV line is required, preferably with a wide bore lumen. You should place a nasogastric tube and perform regular x-rays with periods of regular observations. Side by side this, you should also place periurethral catheter to monitor the fluid balance. And in few cases, you should also consider central venous line to monitor fluid balance in shocked patients. In extreme cases, you should consider high dependency unit or intensive care unit transfer for optimization prior to surgery if required. These are the general principles for the management of the case of small bowel obstructions. There is an alert note if a patient develops any systemic sign of sepsis or peritonism, and what should be your concern? What comes in your mind while this patient has these symptoms? You are right that you should suspect strangulation of the bowel, and it should be kept in your mind. And this is a picture of strangulation of the small bowel obstruction. So what is strangulation? Can you define what is strangulation? Strangulation, here are the pictures of strangulation. Can you judge the blackening of the different loops of the small intestine? So it is defined as venous obstruction occurs first, followed by arterial occlusion, resulting in rapid ischemia of the bowel wall, lead to edema, infection, gangrene, and ultimately perforation of the venous portion of the small gut. And while in large gut obstruction, strangulation is rare except in marvelous. So what will be the manifestation of features of the strangulated obstruction? Patient will be having more tachycardia, there will be more abdominal tenderness, there will be also fever, high grade as compared to simple mechanical obstructions. And in case of TLC, there will be marked leukocytosis, having acidosis, while other laboratory tests reveal elevated serum amylase lipase, LDH, phosphate, or potassium levels. Potassium is more important in these because dead cells release potassium into the circulation, resulting into hyperkalemia. So what is your duty in case of strangulated bowel obstruction? Your duty is having urgent resuscitation and immediate exploratory therapy. These are the few operative pictures in the case of strangulated intestinal obstruction. Look at the color of the segments of intestine. They have resulted into gangrene of small intestine. While in our case, which we discussed as an index case initially, this was a case which was opened, it revealed adhesions inside the abdomen because patient was having a history of previous acceleration of abdomen, having multiple adhesions inside his abdomen. So we performed analysis, released these adhesions, and relieved the obstruction. Laparoscopy can also be performed in case of these cases. Having introduced these laparoscopic instruments, glands or adhesion causing the obstruction should be divided to relieve the obstruction. Remember that these cases of intestinal obstruction, they are 15% of all acute surgical admissions, while these cases occur in 80% in small bowel obstructions, while rest of the 20% comprises obstruction in large gut. While mortality is 3% without strangulation, but it is tenfold, amounting to 30% when strangulation occurs if intestinal obstruction is elongated. And discuss this case, a brief review of what is intestinal obstruction. Any condition which interferes with the normal perfusion and passage of intestinal contents. Broadly speaking, this is of two types. One is dynamic in nature, the second one is adynamic in nature. Dynamic is also called mechanical obstruction, while adynamic is functional obstruction. Dynamic means that hair peristalsis is working against mechanical obstruction, while in case of adynamic or functional results from the atony of the intestine, which with loss of normal peristalsis in the absence of mechanical cause. Or it may be present in a non-propulsive form, for example, mesenteric vascular occlusion or pseudo-obstruction. So this is a table showing different classification or summary of classification. This depends upon the four major categories, depending upon cost, depending upon duration, depending upon its extent, or depending on its type. Depending upon the cause, obstruction is divided into mechanical or dynamic, and second one is adynamic or functional obstruction. The dynamic duration, it is acute or chronic in nature, while regarding its extent, it can be a partial variety or complete variety. Mechanical obstruction is of three varieties. It depends on whether obstruction lies intraluminally or within the walls or extra to the lumen, while intraluminal results from the impaction of the different contents, foreign bodies, bezier phenomena, and gallstones, while intramural or in the wall is with the congenital atresia, strictures, or malignancies, while extratumoral adhesions or bands, herniation, valvulus interruption, or tumor vein or malignant can result into mechanical obstructions. So causes can be within the lumen, within the walls of the intestine, or outside the walls of the intestine. These are a few examples in front of you. Gallstones, which results from the polycystic fistula with release of gallstone inside the lumen of the intestine. This is a pictures of gallstones. This is the retrieve stones. What is this condition? This is intersection. You know, look at this lead point inside the lumen. There is adenoma polyp, which leads to intersection. This is inversion of the proximal segment into distal segment. While in infants and children, duodenal atresia can also present as a case of high intestinal obstruction, and this is an example of intestinal tumor. This is a variety outside the wall of the intestine, which can present dominancy in intestinal obstruction. But remember, common causes of intestinal obstructions: number one is adhesion, number two are hernias, and number three are the tumors. These are the three most common examples. This comprises more than 90% of the cases of small obstructions. We have discussed these mechanical obstructions. These can be partial or complete, and this can be simple with no vascular compromise, closed loop. Both closed loop mean that both ends are obstructed, for example, in case of volvulus. And third variety, which is extreme form of intestinal obstruction, is strangulation of the obstructed segment. This diagram shows the pathophysiology for mechanical obstruction. While obstruction occurs, proximal portion of the blood dilates, which will be having the peristalsis. These peristalsis will try to overcome the obstruction, and it will continue to dilate this segment, while when they exhaust, there will be reduction of the peristaltic strength, resulting in the flaccidity and paralysis of that segment. While segment distal to the obstructions exhibit having normal peristalsis and absorption initially, but later on they become empty and collapses. All these conditions clinically manifest as abdominal pain, distension, vomiting with absolute constipation. So we have discussed various investigations to diagnose the case of obstruction. In this case, pain radiology of the abdomen is of utmost importance. These are the different radiographs of various conditions of the intestinal obstructions. While obstruction with adhesions, these result from the local fluid production resulting into adhesion, and they present as early as 4 weeks post-laparotomy. The majority of patients present between 1 to 5 years. Maximally, they can also present even after 20 years of the initial operation. These are mostly with colorectal surgery, gynecological surgeries, or appendectomies. However, we can prevent these cases with good surgical technique, washing of the peritoneal cavity with saline to remove clots, etc., minimizing contact with the gauze, covering anastomosis and raw peritoneal sepsis. These cases are usually managed conservatively, but when they are not related, again laparotomy can be performed to relieve this obstruction with release of these adhesions. So, what is the take-home message in case of intestinal obstruction? The 4 main cardinal signs of intestinal obstruction are pain, abdominal distension, vomiting, and absolute constipation. In this case, remember you should always examine for hernial abscess. You should be having a plain erect X-ray of the abdomen, including the diaphragm. In these cases, provide adequate resuscitation to the patient, and you should be vigilant enough to look for the signs of peritonitis resulting from perforation or ischemia of the bone. Thank you very much.